So it's my great pleasure here to that Professor Michael Borg is joining us to present on efforts to shift GP prescribing in Malta to narrow spectrum antibiotics. Many of you have the good fortune, like I, to know Professor Borg. So he heads the Department of Infection Prevention and Control at Mater Dei Hospital in Malta and chairs the country's National AMR Committee. He's an honorary fellow of the Royal College of Physicians of Ireland, and he's been included in Stanford University's list of the top 2% scientists in the world. He also has extensive international experience, including past chair of the International Federation of Infection Control and external expert to the European Center for Disease Control. And I think I will add that we all know him, that he is world famous for his insights into behavioral change, and is leading the work in JAMRI on behavioral change. So Michael, it's a great honor. Thank you for joining us. I think we'll say to people that if you have questions while Michael is presenting, please put them in the chat. And otherwise, there'll be time for questions and answers at the end. Great, the floor is yours, Michael. Oh, I think you're muted, Michael.
As usual.
Okay, there you go.
Good afternoon, everyone. Are you seeing my screen? Please?
Perfectly.
Perfectly, excellent. Okay, so once again, good afternoon. Thank you for the invitation. It's always a pleasure. And today, I believe you told me that you've already had two, and I think I attended at least one of them. So you have presentations from the Netherlands and from Denmark, if I'm not mistaken. So all I can say is strap into your rocket, because we're going to go not to a different country and not even to a different planet, but we're going to go to a different solar system. And that solar system is called Club Med of antimicrobial resistance. And we will be, or I will be, talking primarily on the situation in a couple of small rocks exactly in the center of the Mediterranean, with a population of around 500,000, give or take a few. But, you know, from my experience as one of the invited experts in the ECDC country visits, which I like to do in the region. Let me just get rid of this, if you don't mind. I know that these are situations, these are events that will probably resonate, and what I will say will almost certainly resonate well with many of you who are attending, especially from Southern and Eastern European countries. So, welcome to the dark side of antibiotic use. But I love this slide for various reasons. You know, I'm a bit of a Star Wars geek. But for those of you who, like me, you know, are big fans of Star Wars, you know that Darth Vader, who was the arch villain, probably one of the biggest arch villains in movie history, changed over. He managed to change. He changed to the good side. So if Darth Vader can do it, probably so can any physician in our country. So let's now start with what we're here to talk about, namely antibiotic use, and especially, I'm sorry, but these pop-ups are coming up crazily, especially in relation to narrow spectrum antibiotics. Why do we need to emphasize and look at antibiotic consumption in primary care? Well, because mainly that's where most antibiotics are prescribed. This is the data for Malta, and I'm pretty sure that every single country has similar statistics. So in community practice in Malta, more than 90% of all global antibiotics are indeed prescribed in this entity. So primary care physicians are responsible for around 90, if not more, % of all antibiotic prescriptions. So in terms of volume, in terms of the antibiotics that are being used, then this is a critical component. Now, if you look at our situation, I mean, over the years, as you can see from the graph, we did manage to reduce a bit of consumption, and then COVID came, and boy, did our consumption fall nicely. But unfortunately, as probably many of you will also have experienced, this was a bit of an anomaly. The consumption did change, not because there was all of a sudden a new enlightenment amongst prescribers, but mainly because patients were not seeing GPs, either because they were afraid of going to their clinics or to the or wherever the GPs were practicing because of COVID, or else because the GPs actually stopped organizing or holding those clinics in the first place and started to work more remotely, which many patients were not too keen about. And in 2021, we said, oh my goodness, maybe this is something that will have a legacy. And it did have a legacy, but unfortunately, that legacy was the wrong one. So again, in 2022, when we had all those nasty viral infections, our antibiotic use spiked to the highest level in the previous decade. It has come down a bit. So if you look at the ESACnet data that was published last November, we did see a reduction. So at least that massive increase did not persist, but you can see that we are still significantly higher, and which is a pity because over the years, and it is obvious that there will be significant fluctuations because we have small numbers. As I said, we're talking about a country of 500,000, so you will get fluctuations over the years, plus the fact that we do not have, as I will mention, any form of reimbursement. So all the data that we collate for ESACnet comes from wholesaler data, which we collect because they have an obligation to actually report this to our intersectorial coordinating mechanism, to the National AMR Committee. So from year to year, there will be fluctuations, but the trend was on the whole relatively similar to the mean of the EU. But now, unfortunately, since COVID, the legacy is that we have an even bigger mountain to climb. But over here, we are talking primarily about the emphasis on narrower spectrum antibiotics. So we can do a whole presentation about how many antibiotics we can reduce, but today we're talking about the quality. What are we prescribing? And unfortunately, we cannot say that this is where we would like it to be. In fact, if you look at the main antibiotics prescribed in primary care in Malta, these almost invariably fall into one of four groups. It's either comoxiclav, which, if we were to have a Eurovision for antibiotic prescribing in Malta, would get the DISPOA without any competition. And then this is unfortunately followed by macrolides, second generation cephalosporins. I mean, macrolides, it's azithromycin and clarithromycin. Second generation cephalosporins, primarily cefuroxime, almost exclusively. And making up the rear are the fluoroquinolones, mainly Cipro, with a sprinkling of Levo as well. And indeed, for most of these groups, our situation compared with the European mean is not especially promising. As you can see, we have, I would say, how much is that? Almost twice as much consumption per capita of penicillins with beta-lactamase inhibitors, which, as I said, in Malta is mainly comoxiclav. Our cephalosporin use is probably one of the bright spots on the horizon. You know, as you can see, we had a significant discrepancy in the past, towards the beginning of this decade. We did push a lot about cefuroxime and the limitations of cefuroxime, also using the UCAST recommendations, and it made a difference. As you can see, you know, there was year in, year out reduction in cefuroxime, and indeed in 2021 we're actually less than the European median. But once again, that post-COVID uptick with a now above average use. But as I said, this is one of the success stories I believe that we can point to in the past decade or so. One of our biggest headaches are actually the macrolides. The macrolides were always, again, without going into that 2-year COVID aberration, but with macrolides, our GPs love them. They could have them on toast if they could in the morning. And as you can see, we have consistently been well above the European average in terms of macrolide use. Now, why is this important? Well, because if you look at macrolide consumption, again, from ESAC data, and macrolide resistance from EARSnet, there is a very strong correlation with a Spearman R of more than 0.6 and a highly significant p-value. So, not surprisingly, therefore, this is an area where we want to be as proactive as we can, which is not easy to get our GPs hooked off this antibiotic, especially when, as you can see, our resistance to it is so high. So we have something like 30% resistance to strep pyogenes and a bit more even to Streptococcus pneumoniae. So the use of macrolides as an empiric treatment for most respiratory tract infections in Malta is now pretty limited without laboratory support. And this is the message that we are trying to get into our GP colleagues. So you probably saw this in the chart that I have shown already, the same chart. Amoxicillin is practically non-existent in terms of its use. So as you can see, compared to, for example, Carmoxiclav, there is a massive variability. And if we actually compare Maltese use of amoxicillin with the EU average for extended spectrum penicillins, which admittedly will obviously include others, but still, as you can see, major discrepancies and differences. So it's therefore not a surprise that if you, for example, compare narrower spectrum use between the different countries of the EU, again, from ESACnet, we have one of the lowest levels of consumption in terms of DDDs per capita for the whole of the EU. In fact, when you even combine the consumption of penicillin with extended spectrum, beta-lactamase resistant penicillins such as flucloxacillin, and beta-lactamase sensitive penicillins, typically penicillin V, we have the second lowest consumption in the EU. Okay, so again, when I said welcome to the dark side, I was not fully joking. This is a major challenge. And again, it's therefore not surprising that when you look at Peter, thank you very much. So when you look at the narrow to broad spectrum antibiotic ratios in primary care, again, this time we're on the wrong side of the chart. Wouldn't like to be on the right, would like to be more towards the middle or left. And therefore, again, our broad to narrow spectrum ratio is something that we are trying to do something about, and this is, of course, what I will be talking today in this presentation. Having said that, it's not all doom and gloom. If you look historically at our broad to narrow spectrum ratio, you will see that up till 2015, we actually had a trend that was very much on the increase. And since 2015, through a number of interventions, which up till now were mainly educational, we still at least managed to slow down that trend And although we haven't managed to reverse it, but at least it seems that the trend is now stable, it's static. So sometimes it's nice to look at the glass half full rather than half empty. So as you can see, we have lots of data. We are very well aware, even with our limitations in terms of data collection, of where we are in terms of consumption, both in terms of trends, both in terms of what is being prescribed. Where we struggle is who is prescribing it, as I will mention in a minute. But as we say, epidemiology is data for action. It's no use looking at these charts and doing nothing about them, because otherwise the data collection efforts, and they are significant, by all of our stakeholders would be useless. So the question is therefore, where do we go from here? What do we start with? Now, I always like to give my mantra when I'm doing these types of presentations, and that mantra states that behaviors do not materialize in a vacuum. Any behavior comes because the system allows or facilitates it. That is, I believe, a key. Christine mentioned that I am now, I would say, fixated about behavior change, because I believe that that's where we haven't gone to in the past. No? And behavior change, I think this is one of the key cornerstones of understanding behavior change. It's that behaviors it's not Harry Potter, you don't just flick your fingers and they happen. They happen because something drives them to happen. And very often it is the system. So let's have a look at the system that we have in Malta in terms of primary care. So we have a hybrid system, a hybrid setup that goes back decades. And it's a mixture, as you can see from the name itself, it's a hybrid. So we have 9 governmental health centers where resident GPs are present. So the individuals who go to these centers will be served on a first come, first served basis with whoever is working on the day. So continuity of care is challenging. These centers are free to access, but they tend to be very busy because they are often understaffed, and lots of people go there, especially elderly, wanting to have a day off or a morning off and having a chat with whoever is with them in the waiting room. So as a result, if someone wants to go there to be treated, it can take quite some time for a doctor to see you, which not surprisingly has resulted in a flourishing private GP setup, which probably from our ballpark estimates accounts for more than, or at least 80% of all antibiotics prescribed in the country. So these private GPs are paid directly by the clients for the consultation. It is not reimbursed, but the fees are relatively affordable. So people do not see the fee as a major stumbling block to see the doctor. Making an appointment is very easy. There isn't an appointment system. So if you want to see a doctor because your throat is tickling you, you just go to the clinic, wait there, and then you're seen on that very same day. There is no GP registration system, so I can go to a doctor today and go to another one even this afternoon. And therefore, doctors are really focused on making sure that the patient is satisfied, because otherwise he won't come back, and therefore their income will immediately be affected. And just like private GPs are paid directly by the clients, antibiotics that those GPs prescribe will be typically bought out of pocket, and there is no reimbursement, and there is also no electronic prescribing system in place. So these private GPs, therefore, work on their own with no day-to-day peer interaction. because group practices are almost non-existent. They can and often do consult from surgeries within pharmacies, within private pharmacies, because that's not, it can be, it's permissible. They do not require CPD points to maintain their specialist registration, and when they do attend CME events, because of limitations of budget, more often than not, they tend to be through industry-sponsored events. As we said already, these GPs are easily accessible by patients, and we know from Eurobarometer data that antibiotic literacy is not as good as we would like it to be. For example, just one issued, I believe, this week, reinforcing or repeating that about 48% of patients believe that colds are caused by, who are unable to differentiate between viruses and bacteria in terms of colds, and their knowledge that antibiotics do not affect viruses is also pretty low. And as we said already, GPs are very busy. Some of them are really well established. They have a large client base, and therefore time to educate is not exactly unlimited. And it's even more of a challenge in the health centers that I mentioned. So it's therefore not surprising that when you look at Eurobarometer data, you find that a large proportion of antibiotics that are prescribed in Malta, like in many other Mediterranean countries, happens for colds, flu, and sore throat. Of course, all viral conditions. And in fact, the last Eurobarometer, it suggested that more than 50%, just like the previous one in 2016, more than 50% are actually prescribed for these conditions. Now, we've actually polled GPs in sessions that we do. And of course, when we organize sessions, these tend to be the converted people rather than the general average of GPs in the country. But even with the converted, even those who come, they will tell you that, yes, we do know that we are prescribing antibiotics for conditions of likely viral origin, but we do so because 30% will say we are pressured by patients to do so, and the rest, more than half of the GPs, will tell you that they give them just in case it is a bacterial infection, or they know it's a viral infection, but they have this fear of secondary bacterial infections happening. In other words, more than 50% of antibiotics are prescribed for uncertainty avoidance, which again is not surprising. Very often data can always be linked to a cause, and in the case of Malta, we know that when you look at it from a cultural anthropological aspect and look at cultural determinants, in terms of uncertainty avoidance, Malta has the third highest score for EU countries. And those of you who know me know that I am obsessed on this, and obsessed for a reason, I would actually add, because as we know from literature, not just the ones I have published, by the way, cultural determinants arguably best describe the variation of antibiotic use between EU countries in terms of levels of consumption, non-prescribed use in dubious presentations, which we already touched upon, these colds, flus, and sore throats, broad-spectrum formulations that we shall focus so much today, and also in hospitals, unnecessarily long surgical prophylaxis. So indeed, the first study that I am aware of that looked at this was back in 2008 by these Dutch and Belgian colleagues, and two cultural determinants were identified, namely power distance and uncertainty avoidance. I had looked also at, because obviously the challenge we have with colds, flu, and sore throat, and once again, uncertainty avoidance was particularly associated with the prescribing of antibiotics for these conditions, together with another determinant that I will mention called masculinity. I mentioned surgical prophylaxis, and again, if you look at the PPS data, year in, year out, or 5 years in, 5 years out, you see this significant variation between EU countries in relation to surgical prophylaxis. And again, the only associated factor that I am aware of that has been linked to this variability between different countries is once again the cultural construct of uncertainty avoidance. And of course, we are talking about broad spectrum antibiotic use. And indeed, this is an area where, once again, the variation, at least the only explanation for the variation between the European countries that we saw in my chart previously, is indeed culture, and it is indeed, once again, uncertainty avoidance. And in fact, the logarithmic model that we published a few years ago in JAC suggested that more than 50%, almost 60% of the variability or the variation in broad spectrum antibiotic use in the EU can be explained almost exclusively from the country's score for uncertainty avoidance. So what are these determinants that I'm mentioning? So basically they were coined or put forward by a Dutch social scientist by the name of Geert Hofstede. And Hofstede, in his book, Cultures and Organizations, Software of the Mind, and that's the key there, it's a software of the mind. It's how our minds are programmed since childhood. And he has described 6 cultural dimensions that vary between country to country. And in the case of antibiotic use, one of the ones, or the one that actually constantly comes up, is, as I mentioned already, uncertainty avoidance. Now, uncertainty avoidance is all about the ability of societies to handle the daily uncertainties of life and therefore adapt to ambiguous situations. And of course, life is a litany of ambiguous situations. We wake up in the morning and we don't know what is going to happen by the time we go to bed, if we do go to bed at all. And in the case of use of antibiotics and in the case of infectious diseases, then, this uncertainty is even more evident. And it's therefore not surprising that we see that in high uncertainty avoidance countries, antibiotic prescribing is used to reduce ambiguity. It's used to reduce the uncertainty, both for the clinician as well as the patient. So as a result, antibiotics are given even in dubious clinical presentations, what our GP said in the poll, just in case. Those 3 words coin uncertainty avoidance to a T. The use of wide spectrum formulations, because we need the widest possible cover, just to be sure, just in case. And the unnecessary long treatment duration, because again, we need to be sure that they work, just in case. So what happens, therefore, is that in high uncertainty avoidance countries, what we find is that patients, as well as doctors, prefer a safe than sorry approach. Doctors are more uncomfortable than those in lower uncertainty avoidance countries. They're more anxious to making mistakes, and therefore antibiotics are used, or the prescribing of antibiotics is used to reduce this uncertainty linked to this situation. Once again, just in case. We mentioned in a few of the publications the cultural determinant of power distance. And power distance is easier to understand. It's all about hierarchy. It's all about power holders making the important decisions without regarding consultation as necessary or even useful. And power distance is always a two-way street. So yes, you have the power holders making the important decisions, but the less powerful members of the society will then defer decision-making as well as ownership to the power holders. So how does this impact antibiotic use? Well, again, we see it, and I will mention it in a moment, from some work we've done here in Malta, that in countries with high power distance, patients will absolutely divest any input into antibiotic decision making to the clinician. They will not query prescriptions, even probably if they believe they are unnecessary. Now, in terms of the European landscape, this is a very rough graph of what we have, but typically countries in the north are low in power distance and relatively low in uncertainty avoidance. Then, as you go down into Europe, these two cultural determinants increase in their impact, and they reach their highest in, again, the south, and especially the east of Europe. And if you take the ESACnet map, for example, for antibiotic use, you will immediately see a striking resemblance in the coverage of the two maps, even though these are absolutely, or should be absolutely, unrelated. Okay, so even countries that are slightly increased in power distance and uncertainty avoidance will therefore show up in the ESACnet map. And you also mentioned masculinity. Masculinity has nothing to do with muscles. It's all about the levels of ambition, assertiveness in a society. So masculine societies tend to be very result and ego-oriented. So they tend to be societies where you primarily live to work rather than work to live. And therefore, this impacts antibiotics, at least from our work here in Malta, because patients demand antibiotics because they need to get back to productivity as soon as possible. And therefore, they need something to make them better. Okay, so we've seen the epidemiology. We've looked at possible drivers of it. So what comes next? Well, the next thing is that we need to address the behavior. And as Christine said, again, this is now my big passion. This is where most of my research is oriented nowadays, because I believe that this is where we have to go. I always say that my mantra, I have lots of mantras, as you can see, is that AMR, stewardship, and even IPC, these are not medical entities. They are not medical situations. They are behavior situations that are relevant to medicine. And if we want to address them properly, then we address them not by looking at them from a medical perspective, but doing so from a behavioral slant. And when we look at behavior sciences and we see what drives behavior, behavior is driven by three main drivers. It's the capability of the individual to do that behavior, it's their motivation to do it, and it's the opportunity that they get in order to perform it correctly. So when we look at capability is, at least in the combi model that most people who do behavior change nowadays are using, including WHO, including ECDC. So capability is all a function of physical capability, in other words, the skills, the abilities, or the proficiencies, as well as psychological capability, namely knowledge, decision processes, and attention. So how are we tackling this locally? So again, you can see we do try to do as many surveys as we can, because we want to understand why this behavior, because most of it is, to be honest, irrational. So we asked GPs, at a recent meeting that we had, why don't you prescribe amoxicillin? It's what our guidelines say. And we had a varied response, but again, almost three replies stood out. One of them was that they thought that amoxicillin was not suitable for things like sore throat, for pneumonia, for sinusitis, which is where we recommend them. A third said that they thought, again, linked to that the bacteria were likely to be resistant, even though our streptococci are very, very sensitive to penicillins, including, of course, penicillin and amoxicillin. And there was a third, almost a third, who said that they find major difficulties when prescribing amoxicillin for the patient to find it in those private pharmacies that I mentioned already. And therefore, not surprisingly, when we asked them in a follow-up survey, how effective do you consider amoxicillin? I mean, we don't have penicillin V. It's almost impossible to get in the private practice. So it's the best that we can get to be honest, amoxicillin. And if our GPs increased our amoxicillin consumption rather than their macrolides and their cephalosporins, we would really be happy with that. So, it's not surprising, therefore, that even for sore throat, where our strep pyogenes are 100% sensitive to penicillins, clearly there are several misconceptions amongst these doctors, where most of them would say, listen, I would only use, only about 40% of them would use amoxicillin, and ironically, the others will prefer either a much broader spectrum, that uncertainty avoidance I mentioned, even though it's not useful, if it is a bacterial infection, it's going to be strep pyogenes. And some, about, yes, admittedly not that much, but around 10% will go for a macrolide when we have been telling them for the past 3 years that the resistance in strep pyogenes is at a level where empiric treatment is not recommended. What about motivation? So motivation, at least in the COMBI model, split into two main entities. There is the automatic motivation. It's when we do decisions, almost automatically by autopilot. Habit falls under automatic motivation. And then you have reflective motivation, where it's you think about something and you are motivated to behave in a certain manner. Now, the thing with motivation, especially in terms of antibiotic use, is very complex. This is a very nice study. I was really privileged to be one of the supervisors of Erika Saliba's PhD, which she did in Malta. And she has, I may be biased here, but I think she has produced some of the best qualitative studies looking at antibiotic prescribing in the Mediterranean. And this phenomenographic study that she did identified that there are so many motivators amongst GPs. Some of them, what Erika called the service providers. In other words, they want to maintain a good relationship and they don't want to pay the patient to go to another doctor. Maybe there are obviously motivations there. The uncertainty avoider, again, we come to that, providing treatment just in case. The comforter, which again has an element of uncertainty avoidance. Then you have the conscientious practitioner, and that's obviously where we would like to motivate our doctors, that they will empower and educate their patients. But unfortunately, when you have a high power distance, you do have a lot of holders of professional power, in other words, those who regard antibiotic prescribing as their domain, and it's something that they need to control from start to finish. And the other, of course, automatic motivator is what we mentioned already. It's the patient demand. Very nice quote from Erika, saying that when I fail to convince a patient, I would just give an antibiotic, because I don't think it will make a difference. Now, from what she said, at least from her focus groups, many said that they were relatively unaffected by patient pressure. But of course, we saw from the poll earlier that about 30%, more than 30%, actually said that they do prescribe because of that. And the third component of the behavior change wheel is opportunity. Okay, so opportunity is all about physical opportunity, having a system that allows you to behave in the way that you would like to, or that is ideal. And the social opportunity, whether there are social norms, social pressures, social need to conform, which we know especially is very strong in Scandinavian countries, which will therefore explain why antibiotic use is so much better over there. And of course, when you have the system barriers that I mentioned, the opportunity, the counter opportunities, I would say, by the private GP system, by the fact that they're working alone, so they have no motivation or no feedback from peers. The fact that there is no oversight or consequences. I mean, imagine if we could drive in the way we wanted to without any form of consequence or penalty. I'm pretty sure that driving would not be in the same manner, especially in the countries where there are proper checks on this. The fact that there is a minimum use of rapid tests, which we'll mention later on. The fact that the system does not allow individual prescribing patterns to be given to the doctor, and of course, this issue of patient demand. So opportunities and systems are critical when you are devising and coming up with possible interventions. And those interventions, as again, we know from Susan Michie's work and her colleagues in terms of the behavior change wheel, there are a number of interventions that we could do. We could do education, we could do things like persuasion, trying to induce positive feelings, incentivization, creating a reward, or as coercion, creating a punishment, so positive or negative motivators, doing skills training, restricting opportunities for prescriptions, such as gatekeeping, for example, environmental restructuring, where you're looking at changing the physical or social context, modeling by having peers, assisting in behavior change, and enablement by producing or reducing barriers to incorrect behavior. So in terms of what we're saying, so we look at the psychological capabilities that we can do here in Malta. Well, training is extremely difficult because these doctors are working on their own. There is no obligation to do so, as we said. They're very busy, so they're definitely not going, and many of them are senior, so they're not going to come to do training. So most of our options when looking at psychological capability are indeed education and enablement. So in terms of education, what we have worked on were primarily looking at education in the training program for family medicine. Of course, like all EU countries, family medicine is a specialty in Malta, and you have to do a number of years of training. So we've improved that there. We're also moved our CME initiatives online, because obviously these very busy doctors are not going to come, and spend a half a day with you. So we do them in the evening. When they go back home, at least to try and find the slot where it's most convenient for them. Still, we cannot say that they are overwhelmingly attended, and unfortunately, it tends to be the usual crowd that of the converted that tends to be attending there. We are now in the process, again, thanks to our participation in the Access work package. We are developing a Moodle type course, again online during this year, that will provide some form of education and training in the importance of narrower spectrum prescribing. But we know that this will only have an impact if we can make it in some way mandatory. Because if we leave it as it is, Einstein, I love Einstein's quote as saying that insanity is trying to repeat the same thing over and over again and expecting a different result. So if we want a different result, then we need to change what we're doing. And that would be, if we can, in some way, and we're trying to push on this, but not easy. Politically, there isn't much support of making CME points in AMR and AMC obligatory for registration. And one thing that we do is we send out regular updates to our doctors, both in government as well as private practice. This is the last one we sent out in AAD of last November. And it does make some impact. So we asked actually the doctors we sent the update to whether it made a difference on their prescribing decisions regarding amoxicillin, and what in the update convinced them. And about half said yes, it made a reasonably significant impact. And of these, the reason for this is because, again, they saw the data on sensitivity in streptococci. Another third said it's, again, because we saw what you told us, that the antibiotics we're using, especially the macrolides, are so resistant to these streptococci. And the fact that we gave them information on amoxicillin availability, because if you remember, this was a barrier that we identified. So again, this was something that convinced them that they could prescribe more amoxicillin. Now, as I said, enablement is all about providing tools. And of course, like all countries, or at least most countries, we have our national guidelines, which were drafted and revised after reviewing the current evidence, and especially after looking at our own local resistance epidemiology. Where we maybe are a bit different, at least from most of the algorithms that I've looked at, or the guidelines I've looked at, is that our national guidelines are presented in an algorithmic-based decision-making pathway. In other words, they have an app. So they go on to, I don't know, community-acquired pneumonia. It would ask you a number of questions, guide you to the process, and at the end, it will suggest the most indicated antibiotic. And again, we devised this because we know we are working in an environment that is high in uncertainty avoidance. So if we give them 3 options, they will almost invariably choose the broadest spectrum option of those. So we guide them through the process and then suggest one option, depending, of course, if it's penicillin allergic, etc. Well, of course, like all tools, you can produce a tool, but the individual needs to want to use that tool. So again, we have major challenges with getting doctors to use our guidelines. It's not just us. Again, from my experience in the AMR country visits in Southern and Eastern European countries, I know that it's a massive challenge for many of us to actually get doctors to do guidelines. And this is, again, behaviorally explainable. Because if you have a high uncertainty avoidance culture, then what is certain for the doctor? It's not the guideline that someone at, I don't know, in the middle of America produced this systematic review, which he or she has no impact and very little actually understanding of, but it's what he or she is saying. So if he gave the patient Comoxiclav for a sore throat or for a cough, and that patient got better not because of the antibiotic, but in spite of it, then that antibiotic works. So that's the certainty. Not surprisingly, guidelines, the concept of guidelines has actually come from Anglo-Saxon and Scandinavian countries, both of which, as you saw from the map, are low in power distance and low in uncertainty avoidance. So what about opportunities, especially social opportunity and especially physical opportunity? Well, we have many barriers there. As I said, training is difficult. Restriction is impossible. We cannot restrict what doctors prescribe, at least by our current laws. So where we go are primarily things like enablement, as we mentioned, but also environmental restructuring. So what do we do in environmental restructuring? Well, we saw the impact of COVID, and we saw how the fact that patients were not seeing doctors reduced the use of macrolides, reduced the use of Comoxiclav, and reduce the use of cephalosporins. So our campaigns actually try to, as much as possible, help patients not to need to go to a doctor. Because we know that if they go to a doctor, the chances are that they will be prescribed an antibiotic, and that antibiotic will almost certainly be a broad spectrum formulation. So this is one of the tools that we have, or the posters that we have issued from the National AMR Committee to the population, helping them understand that when they have a sore throat and their Centaur score, this is basically a simplified Centaur score, is 0, then they don't need to see anyone. They can go to a pharmacy and they can give them some alleviative medicine. And again, same thing. This is what we issued this year. Flyers, handouts, emphasizing that antibiotics are not effective on colds. They're not effective on flu. They're not effective on sore throats. So at least we try to reduce that demand. But there's also an opportunity issue that I have already alluded to, and that is the availability of narrower spectrum formulations in private pharmacies, because as we said, those are where 80% of antibiotics are purchased by the patients. And I've already mentioned that we have major, like most countries in Europe, major challenges to source penicillin V. We do have narrower spectrum oral tablet formulations, so amoxicillin is now thankfully, and it was quite difficult actually to get this, available in private pharmacies. We have cephalexin, but syrups are extremely difficult. Other than amoxicillin syrup, narrower spectrum and pediatric formulations are almost impossible to find in private pharmacies. But that's not the whole picture, because even if they are available, they need to be prescribed by doctors. And this is something that is the other challenge. So one challenge is actually having the narrower spectrum formulations there. The other challenge is getting doctors to prescribe them. And as you can see, this is something we've just issued this week, looking and asking them asking pharmacists how often do they get prescriptions for these narrower spectrum antibiotics. And as you can see, it is not very common as compared to something like Comoxiclav, where a pharmacy will probably dispense something like 10 or 15 or even more packages a day. So it's all about the chicken and egg scenario. If you push the prescriptions and the antibiotics are not in the pharmacy, then you are discredited and the doctors will not prescribe them again. If you push the pharmacists or the wholesalers to import more narrower spectrum antibiotics and they're not prescribed by the physicians, by the GPs, then it's the last time they will do so, because they will end up throwing away thousands of euros of merchandise, and they will tell you, and they have done it, and we've gone through this, never again, don't even talk to me about importing these narrower spectrum formulations. So what we're looking at, and we actually had a meeting of our national committee just last week, are pull incentives which we can look into. And two options that we are trying to push is either having private importers getting the key narrower spectrum formulations and doing so with the guarantee that if they don't sell them, they will be reimbursed for any losses, or else seeing if our governmental system, which already distributes free medicines to private pharmacies under a scheme called Pharmacy of Your Choice, if we can also latch on to this, and the government will import these essential narrower spectrum antibiotics and then distribute them to pharmacists who will then sell them. It's literally sell them to pharmacies as they would a wholesaler. We're still in the very beginning of this, but hopefully it is something that we can look into pushing, at least, if not in the immediate future, but in the near future. But we also will have barriers, so these are the feedback that we got from physicians who said, no, the leaflet that you sent us did not make any impact on my prescribing. And two of the most common quotes were, I prefer to stick with my usual tried and trusted formulations, and my patients expect other antibiotics for these conditions. Again, uncertainty avoidance coming out pretty heavily there. So finally, and we're getting to the end because I don't want to spend more than an hour on this presentation, what about motivation? Well, as you can see, there are various options for motivation, both automatic motivation as well as reflective motivation, but many of them, as I have already mentioned, are very difficult for us to actually implement because the system is a massive barrier. So there are, for example, possible enablement. So one of the areas that we're looking at is to improve the use of the strep A test kits, because that will impact on the automatic motivation that, this patient has a sore throat. I don't know if it is bacterial or not. So just in case, I will cover it with antibiotics. So if we can have something which is certain, where they see the result in front of their face, then hopefully, and there are obviously papers that have shown this, then hopefully this will impact on the prescribing. But once again, the system is a problem. So there are numerous barriers. The fact, for example, that this will increase the cost to the GP, which the GP will then pass on to the patients, is going to be a problem. Because what you will then have is GPs who don't use this will have cheaper consultation fees than those who will, and obviously those who are charging more will not like this. No? And even in governmental clinics, the ones I mentioned, those 9 clinics, where it would be free, we still have massive barriers because doing this test is going to increase at least 15 minutes of the doctor's time. And to be honest, they don't have another 15 minutes per patient to spend on this. And trying to get other stakeholders, such as nurses or assistants, to do it, that has been a brick wall because of various local cultural issues. So, this is why behavior is so important when planning these interventions, because they are anything but simple, because you will always have massive barriers. So in our case, the system eliminates motivational change levers, which in other countries and maybe in publications would have been very useful. So things like training, restriction, modeling, not possible to do. There is very good evidence, most recently, I believe, from the UK, where they showed that sending the high-end prescribers a formal letter indicating that, listen, you're at the top end of the prescribing and sort of, can you justify why you are there, etc., etc. This makes a difference on prescribing behavior. But it's something, again, we cannot do because we have no forms of identifying individual prescribers. So to conclude, because I've taken about 50 minutes of your time, and I think you've heard more than enough of my voice. So I think this is the key I would like to finish with. No? If we are going to do any form, and this is what we continuously talk about and discuss internally when we're looking at these interventions that we are doing, both in stewardship and also in IPC, which is where, of course, work package 7.4 and my interest in it is. So effective behavior change interventions must be multimodal. There is no good evidence that education on its own changes behavior. At least there is absolutely no evidence that education on its own offers a guarantee of behavior change, especially in environments which are culturally challenging. So it has to be a combination. It has to be a combination of education, of training, of motivational tools, and of course, changing the system, which, as you saw, is one of the biggest challenges we have, one of the biggest barriers we have, but it's something that we need to address, because if we don't change the system, it's highly unlikely that we'll get more success than we have. So to conclude, in community antibiotic prescribing in terms both of total numbers, but especially in terms of quality of prescribing, has numerous challenges in our country, many of which are related to the system as well as our national culture. There is clear evidence of both overuse of antibiotics as well as unnecessary focus on broad spectrum formulations, which in turn is impacting on resistance levels in community isolates such as strep pneumonia, strep pyogenes, and E. coli, to macrolides, and we didn't mention it, fluoroquinolones. And as we saw, and I hope at least I managed to convince you that antibiotic prescribing is the consequence of highly complex behaviors and systems. And therefore, because it's complex, there is no single simple solution. It has to be a multifaceted behavior change interventions. We are piloting, and I didn't want to take more time to describe it, but we are part of the TAP initiative of WHO. And we are doing a pilot through one of our colleagues in the governmental health services, or center, sorry, where they actually do have some form of electronic monitoring of prescribing, but extending these to the private sector, as we discussed, is a major challenge. But there is no doubt that we need major system changes, of which electronic prescribing is critical, and the guaranteed availability of narrower spectrum products in private pharmacies, especially of formulations for children, is critical. And finally, I will finish off with what I started already. It is challenging. It's very tempting to continuously look at the glass as half empty, if not mostly empty. And it is a challenge, but interventions are still possible. And you saw that we did manage, for example, to reduce the cephalosporin use. We did manage to get some impact on at least the highly motivated GPs. So just as Darth Vader changed, I think we all, even in the most challenging countries in terms of antibiotic use and AMR, we still can do something, maybe not as effectively as maybe other conducive environments, but we all can do things in order to improve. The only thing I would just say and finish with that is just avoid copy and paste. If it's just because a system works in Sweden or Denmark doesn't mean it is going to work in the middle of the Mediterranean. So we need to understand our culture. We need to improve our awareness of behavior change and use those tools, use that knowledge to drive effective interventions in our patch of the woods. And with that, I thank you very much for your attention.
Thank you very much, Michael. That was excellent. Very, very enjoyable, and a lot of information and good experiences there. So thank you very much. If you'll stop sharing your screen.
I'm trying to. Okay. Okay.
Yep. There you go. Great. Wonderful. So now it's time for the discussion, and I'm sure many people here have questions. So when you have a question, just raise your hand or put it in the chat, and we can go through those. So I guess I can start. I'm curious if you can tell us about how you managed to get amoxicillin, because it seems that initially that you did manage to get a hold of some amoxicillin, and now it seems like that it is available in the pharmacies. Yeah. So can you tell a little bit more about how you managed to do so?
Yeah, I mean, that was one of the few silver linings of COVID, actually, because as you know, Chris, I mean, COVID, we had massive antibiotic shortages throughout Europe. So whatever antibiotic private wholesalers were finding on the European market, they were importing into Malta because they knew that it would be used by the doctors. And that sort of served as the way in which we slightly opened the door. And then we started to push a lot the need for amoxicillin. So basically, we became the reps for the amoxicillin importers. which I have no problem with because, it's what we want to achieve. So we sort of said, listen, we are saving you all forms of advertisement for your antibiotics. And it wasn't just one importer, so there were a couple of different importers, but we would like you to keep importing them in. Some did, some didn't. So one of them said, sorry, I've tried it once, as I said, and I've lost 10,000 euros and I'm not going to lose them again. But with a bit of convincing. It's a small country, we know each other. Very often with many of these people, you're either at school or at least at university. So, the human element does help when you're a small country. So being small has its many disadvantages, but it does have a few advantages. So we've managed, at least up till now, to convince these pharmacies. How or can we sustain it? I hope so, but we'll see.